What are the antibodies that are looked at in EBV reactivation, and how do you read them? Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor practicing in the state of Minnesota. So in a standard EBV panel, this is going to be something that your doctor can look up, and they'll immediately see that the lab has offered a panel of 3 different antibodies. Usually in this standard panel, there will be 3 different antibodies that are looked at. 2 of them generally are against something called viral capsid antigen, and 1 of them is against something called a nuclear antigen of the Epstein-Barr virus. And basically what an antigen is like a part on the virus, and that is the part that your immune system has made antibodies towards. And we're testing for the antibodies that are towards that part of the virus. And in these 3 antibodies, there's 2 parts that are being looked at the virus, and there are 2 types of antigens. One is called an IgM and one is called an IgG. So IgM is an antibody that generally your body makes against acute infection. This is when something is happening. Like the virus is here and we need a response really quickly. This is the antibody that your body makes in response to that. We need something fast. We need something right now to try to fight this virus. That's IgM. IgG is the other type that has a little bit of a longer ramp up time. It does have better immune memory where it remembers what the virus looks like. So it can activate quicker next time you see this virus so that you can fight the virus off. So IgM and IgG. Generally in this panel, you will have the IgM and the IgG titers meaning how much there is, against the VCA, the viral capsid antigen. So EBV-VCA IgM, EBV-VCA IgG. Those are 2 of them. And then you have a third one that is VCNA, nuclear antigen IgG. These are the 3 antibodies that are typically looked at in a very simple EBV panel. And generally the way that you would read this is if the IgM, VCA IgM, is high and the other 2 are low, then this is the first time you've ever had EBV. And we've caught it probably within the first 8 weeks of you having it. If the IgM is low and the 2 IgG are high, this means that you've had EBV before. And potentially you don't have a reactivation right now. It might just be that you've had EBV in the past. And now with reassessment of Epstein-Barr reactivation, if you see that all 3 of these are high, then it's very likely that you had a latent, you've had the infection before. The EBV was latent in your body, in which case your body didn't need to launch the IgM at all. But now maybe that virus has entered what's called the lytic phase, which is another activation phase, and your body has created more IgM. So, if your IgM and both of your IgGs are high, then maybe you caught it at week 4 while your IgG was still ramping up of the first time you've had this infection. Or another case scenario is that you've had this infection before, which explains the higher IgG levels, but it's reactivated and now your IgM is high again. So that could be an indicator of reactivation of EBV antibodies. I think the issue with this is that usually with elevated IgM titers, that goes up and then goes down in 8 weeks. And then you have to kind of look at how high the IgG titers are. And this is the part that's a little bit controversial because there are subsets of clinical thinkers who feel like it shouldn't matter how high the IgG antibodies are. But there's also research about IgG titers being really, really high, much higher than a general immune immune memory level that is associated with development of MS and things like that. So how high the titers of IgG I think is also clinically significant, and we aren't seeing that in clinical practice yet. We're seeing that in clinical research, but not practice yet. But I think eventually it will start translating over. And I think there's another antibody that needs to be looked at for sort of more clinical confirmation of whether or not reactivation is happening. And this is the IgG early antigen D. And this is a antibody that rises specifically at the peak of the lytic phase, which is the reactivation phase of that virus. And unlike IgM, which only happens about in an 8-week period of time, Early antigen D can persist for about 3 to 6 months, so you can catch it a little bit easier, especially if you're experiencing a lot of symptoms of chronic fatigue or a lot of other like neurological symptoms that typically you associate with EBV reactivation. So in general, 4 antibodies that I would look at, 3 of them are part of a basic panel. One you might have to order separately. It's the VCA IgM, VCA IgG, NA IgG, and early antigen D IgG. And if you see the IgM or the early antigen D elevated, then those are indications for viral treatment. You probably want to be on antivirals to treat the reactivated EBV, or if it's a first-time EBV infection. The IgG ones are a little bit more controversial. If these are elevated but within the dynamic range of the lab, usually I would say you probably don't have a problem with EBV. It might be something else that's causing your chronic fatigue or other symptoms. Let's go work up something else. But if especially the IgG nuclear antigen, NA, the IgG NA, is high and like above the dynamic range of the lab, where it says it has like a greater than and then the top number of its range, that might be worth putting at least on the back burner to think about, to see if we can try to work on your immune system again, or any other antiviral therapies where we might see some reduction in that antibody titer in particular, because we know that a titer that is that high, even years before development of a chronic disease like MS, it is linked to like, it has, in the research, there is a 12-fold increase with someone who has a titer that is that high of EBNA IgG who develops MS compared to the general population. So that is a antibody titer that is worth looking at and seeing if there's any way that we can, make it not do that. So hopefully this helps. In the next video, I'm going to go over some therapies and maybe why we need to update from like monolaurin and lysine, which have been our traditional staples in alternative medicine. Setting aside the controversy of reactivated EBV, here's how I would read the serology. I realized I was being a little bit unclear and rambly in the previous video, so here's how I read serology in terms of reading for like reactivated EBV. Okay, generally I look at these 4 antibodies. These 3 antibodies here, you're very likely going to be able to find on a standard EBV panel. These are very often grouped together, whereas the early antigen IgG here, very oftentimes it's on its own, and in my experience, this panel costs the same as this one antigen, which is kind of stupid, but here we are. Now, if you had a positive IgM and negative IgGs, and the early antigen D could be positive or negative, this means that you probably do have EBV. You probably feel pretty crappy right now, and this is probably the first time that you're getting EBV. And the hallmark of reactivated EBV is that these 2 antibodies are positive. So whenever you have a reactivated EBV, these 2 have to be positive, because the IgG antibodies tell us that this is something that your body has seen before. Now, what distinguishes this picture from just that your body remembers seeing EBV and having an EBV viral reactivation right now is the IgM and the EBV early antigen D. So if you're seeing all 3 of these positive, then that's telling me that your body is likely fending something off. I like using the early antigen D as a marker as well, because if this is positive, this is more likely going to catch within the past 3 to 6 months. Have you had a reactivation? Are you still currently in a reactivation? Sometimes the IgM is a little bit less reliable, but I do see that this elevates in some people where all of the antibodies are elevated, and this person is dealing with a lot of active symptoms like chronic fatigue, neurological symptoms, fibromyalgia type symptoms. And so to be absolutely clear, I would treat for reactivated EBV if all 4 of these were positive, or if these 2 plus 1 of these were positive. And there is a special case here in which I would treat a little bit differently as well, which is if this is negative, this is positive, and this is also negative, but the positive with the EBNA here is greater than 700, or wherever the lab cutoff is, because we know in the current research that if somebody has really high titers of the Epstein-Barr nuclear antigen IgG, this is what can predispose to developing MS up to like 12 years. Like I forget how many years it is, but I think it is a 12-fold increase in terms of developing MS. We have linked lupus to Epstein-Barr virus. We have linked certain lymphoproliferative cancers with Epstein-Barr virus. And this antibody in particular, there's in the research has been talked a lot about like molecular mimicry and the way in which these antibodies can mimic certain aspects of our own body, including like our myelin sheaths and our own cell's nucleus in the case of lupus. So when this antibody is really, really high, this is something that I want to go in with like a little bit of a preventative lens as well. And I know there have been people asking me whether or not I look at PCR specifically. I don't really personally, because I think with PCR that tells us whether or not there's like an active viral load in the body, but for the most part, I can get a sense of whether or not your immune system is struggling from the serology itself. And full disclosure, there's a lot of controversy revolving around reactivated EBV and looking at the serology versus looking at the PCR. In my clinical practice, I tend to see a lot of fringe cases. So from my perspective, I think just weighing the pros and the cons with the people who have not been able to find any cause for their chronic fatigue, fibromyalgia symptoms, or neurological symptoms. Very oftentimes, if we take an approach that hits EBV in a certain way, so using antiviral herbs or using anti-inflammatory herbs that are neuroprotective, many times I do see like clinical improvement in their symptoms. So for me, it's really a pros and cons discussion with the patient on like what they're willing to try, what they're willing to look into, what they've already been worked up for, and what makes the most sense in their care. Let's talk about acute infection of EBV, Epstein-Barr virus. So this is generally the picture of mono. This is quote unquote kissing disease. This is the thing that back in the day, teenagers got really often, and then they would be out and sick for months with like a really swollen throat. Maybe they were monitoring their spleen to see if their spleen was getting big. But yeah, when you get an acute infection of Epstein-Barr virus, this is when you would first do like workup, differential diagnosis of like, what is this? Is this mono or is it strep? Because very often that's your main differential. And so you would go possibly to urgent care, possibly to your primary care doctor. They would do a monospot, they would do strep testing, and this would generally be treated as acute. You would have treatment possibly for the pain in your throat, and then some other things depending on what your situation is. Some doctors will prescribe Valtrex or like acyclovir, so acyclovir or valcyclovir as an antiviral to treat EBV in this way. Very typically, probably not. If you go to a naturopathic doctor, very often they might give you some supportive herbs for this. And I did say that I was going to talk about my notes on EBV that I learned back in the day from Dr. Paul Anderson, and this is what he wrote down for an acute first reaction. Generally, he is also a naturopathic doctor, so he talks about herbs. There's a really famous formula that's abbreviated as HEMP, H-E-M-P, because it is Hydrastis, Echinacea, Myrrh, and Phytolacca. The Hydrastis, Echinacea, and Myrrh are generally like antimicrobial in some way. The Phytolacca is in there for lymphatic support, because with a lot of mono, there's like a lot of swelling. So you want to have a small amount of lymphatic in there as well. And the hemp formula is equal parts of these 4 herbals, and it's dosed every 2 hours during the acute phase, at least for 2 days, and then every 4 to 6 hours after that. So this should generally give you a good antimicrobial, antiviral support while you're dealing with like a first acute infection of mono. There's also a sore throat tincture that I learned here back in the day with the formula. And this one has 5 herbs in it. And it's a gargle and swallow type of thing where you want to have those herbs sitting at the back of your throat, especially if that throat is really sore, and then you swallow it after you gargle. And the herbs are Baptisia, mentha, which is any type of mint, berberis, and Phytolacca, and lomatium. And lomatium in particular is a very, very good antiviral herb. It's very often used in antiviral formulas. The other thing I have here is an iodine gargle, which, maybe not, depending on your iodine sensitivity. I have really stepped away from a lot of iodine dosing since I've started treating Hashimoto's thyroiditis a lot more, because that population can be very sensitive to both how much iodine they're exposed to and the type of iodine that they're exposed to. I can talk more about that if anybody is interested. Also noted here is vitamin A as a retinoid, not as a carotenoid. So vitamin A as a retinoid is pretty directly antiviral. It's very immune system supportive, as is vitamin D at a higher dosage. Now, it's important to note that both vitamin A and vitamin D are fat-soluble vitamins, so this is definitely a short-term dosage type of situation, especially if you're dosing it a little bit higher dose. And for vitamin D, I would consider high dose like anything above 8,000 IU. I know people can go really, really high with the vitamin D dosages, especially since nowadays 50,000 IU capsules are available over the counter, which I have slight opinions about, because people don't know that's once a week dosage typically. So if you take 50,000 every day for a long term, that's not very safe. Other things, monolaurin, which I know is like a very traditional staple in the treatment of EBV. Monolaurin can be useful in the acute and early reactivation. So like for acute situations here, monolaurin might be very helpful. But it's not so effective in chronic complex reactivation. But if you're having acute reactivation, you want to ramp up by gram doses. So generally, I don't have the details in my notes here. I'm sure Dr. Paul Anderson goes over them. But in my practice, what I will start with is generally 500 milligrams twice a day, so 1 gram a day, and then ramping it up to about 3 grams per day. And then we stay on that dosage for maybe 2 or 3 weeks. Sometimes in reactivation, I will have people on that for maybe like a month or 2, and then we ramp down. Monolaurin is very nonspecific, and I know in the literature right now, we know that monolaurin is researched to have general antiviral effects, but there's no actual research showing that it is specifically antiviral to Epstein-Barr virus. So I think it's a really good support for when you are getting a viral infection, especially when flu season is rolling around and you start feeling sick. The chances that it is viral, either influenza, COVID, EBV, something else, the chances that it is viral is, at least in the adult population, much, much higher than a bacterial infection. And bacterial would be like strep throat or something like that. So in general, for acute infections, that's how I've learned to treat acute mono before. I think in my practice right now, it is much easier to do capsules for a lot of people, especially if they have a capsule formula that is on hand, that they can just have in their cupboard, and at the first sign of illness, they're able to reach for that capsule and then just take it that way. I find that, at least in my patient population, getting capsules and storing capsules is a lot easier than storing tincture formulas. So in my population, when flu season starts rolling around, and I'll do another PSA on this too, because I think this type of thing is important with Thanksgiving and Christmas coming up, where people are generally gathered together and there can be a lot more risk for passing viral illnesses around. I like using andrographis-based formulas. Andrographis, I think, is a fantastic herb that has a really broad antiviral spectrum, and it's also antibacterial and antiparasitic in some cases. It has not been as overused as, say, like berberine or artemisinin, so there's a lot less resistance to andrographis products, and it tends to work really, really well. Okay, product mention, but one of my favorites, at least for the past 2 years, has been, there's a formula called Viracid by Orthomolecular that has quite a hefty amount of andrographis in it. It's harder to use for kids because andrographis is also extremely bitter, so you can't really break open the capsules. There's another formula that I'm currently experimenting with that has a lot of good antivirals and a pretty hefty dose in it, and this one is called Complavir Mint by I think the company is Nutrabiogenesis. The main feedback that I've gotten from that, looking at the ingredients, they look really great at really good dosages. But right now, one of the main pieces of feedback that I've gotten for that formula in particular is that they are big oval tablets and they're very difficult to swallow. So if it's just about the number of pills, then the Complavir Mint probably is going to get the best bang for your buck. And the Viracid is less capsules. They're smaller capsules. They're standard 500 milligram capsules, and they work really well, and they're much easier to swallow than the Compilation mint, I guess, but you would have to take the Virasid generally. I dose 2 capsules 4 times a day when someone is having the first sign of illness. And again, none of this is not medical advice. Please talk to your doctor before starting any herbs, but those are generally stuff that I recommend in this season of time when flu season is rolling around. And also, just a disclaimer, I do prescribe those products in my practice, obviously, but I don't have any financial ties to those companies, so there you go. I don't get paid if you buy them from the companies, is what I'm saying. Are there any brain tumors that have been associated with chronic EBV? Not my specialty, but I did look it up. EBV is a well-established cause of several lymphoid and epithelial cancers, including Burkitt lymphoma, Hodgkin's lymphoma, and nasopharyngeal carcinomas. In the case of brain tumors, it has been most notably linked to primary central nervous system lymphomas, also abbreviated as PCNSL, especially in immunocompromised patients and other rare smooth muscle tumors of the brain. It's of note that these are correlations with EBV reactivation and EBV infection, but evidence for like a direct causative role for other malignant brain tumors are kind of controversial and inconclusive for right now. There was a paper published in 2004 in the New England Journal of Medicine. The PMID is 150-44644, if you're interested in looking that up. It has a little table here. Let me just show you. Okay, so hopefully this is big enough that you can see. This was from 2004, and there's a definitive role for, infectious mono, because it is what causes infectious mono and X-linked lymphoproliferative disease. There was a strong association with these cancers back in the day, and back in the day we were still wondering about rheumatoid arthritis, lupus, multiple sclerosis, breast cancer, and chronic fatigue syndrome. This was back in 2004. Our data has been updated. Currently, there is really strong epidemiological and mechanistic evidence for EBV as a causative factor in MS. And I can list all of the PMIDs right here. We also know that EBV is linked to systemic lupus erythematosus, lupus, Sjögren syndrome, rheumatoid arthritis, Graves' disease, EBV-associated smooth muscle tumors, EBV-associated gastric carcinoma, EBV-associated NK T-cell lymphoma, and EBV-associated T-cell lymphomas. There are also a handful of other cancers that are involved in the pathogenesis of other cancers that have EBV play a role in. So what we know right now is that EBV is increasingly implicated in a range of systemic autoimmune diseases and systemic lymphoproliferative diseases. And we think it's because of EBV's ability to just camp out in our B cells and make things not great for us. But yeah, research is still coming out on a lot of a lot of the chronic diseases that EBV might have a role in causing. So I think looking at EBV a little bit closer and implementing a little bit more prevention around Epstein-Barr virus and really taking any sort of reactivation or off-the-charts antibodies a little bit more seriously can be really important for the future health of our patients. So how is EBV reactivation treated, and is it treated differently from the initial infection of EBV? Hi, I'm Dr. Joyce Knieff. I am a naturopathic doctor practicing in the state of Minnesota. So when it comes to Epstein-Barr infection, there are generally 3 different phases. There's the first acute infection, which is mono or something like that. And then there's an early reactivation, and then some people have chronic complex reactivation, and these all look slightly different. So in the first acute infection, this is generally when you have the really swollen throat. You want to do a monospot, which is a test for whether or not it's usually a blood prick or a blood draw, strep testing, and the treatment is generally acute antivirals if you need to, mostly herbals and stuff. Basically, your goal here is to have as complete as a immune response as possible. And you can also have a lot of treatment for pain too, because a lot of times there's a lot of pain in the throat. And then people who have early reactivation are not really that sick. It is kind of more of the start of chronic illness. And this can be a picture where it just resolves by itself in weeks, either with herbals or without herbals. And this is where you have a early antigen IgG that is elevated. And this early reactivation picture can be things like when you have fatigue that comes in months and then you're better for some months and then it comes again in months. Generally, it's the picture where you have the reactivation of the virus, but the immune system is still resilient enough that given some time, it can beat the virus back into submission. And then you get to more of the chronic complex reactivators. This is when you get sick multiple times. Potentially you have less good days than bad days. This is when we're looking at things like, do you have any co-infections that are other viruses in the herpes virus family, or did this all come on because another virus has challenged your immune system, like the way that COVID has? There can be biofilms, there can be mitochondrial issues, there can be like other toxic load. So like if you've had any mold exposure and that's challenged your immune system, then maybe your immune system is too busy with that than it is to like be able to beat back something that is coming out of storage, like the EBV. And treatment in each of these phases are going to be slightly different. With the acute phase, you're going to have a really strong ramp up, really strong ramp down, and then generally the duration is much, much shorter. As long as you can get sort of a complete immune system response, then usually you will be in a pretty good place from then on. From like an early reactivation standpoint, generally this case is like you want to treat out pretty aggressively, maybe for 2 or 3 months, and then generally you can back off to a little bit more of a maintenance type of situation. For the chronic complex reactivator, this is where things get a little bit dicey. This is when you have to be sort of careful if somebody has any sort of sensitivities. You don't want to blow them out with antimicrobials before you like really help support their body's systems with like nutrients and herbs that are a little bit more tonifying, because they've been chronically ill for a long time. They're pretty depleted, so you have to be pretty gentle. And I did dig up some of my old notes from when I learned how to first treat EBV from Dr. Paul Anderson. So let me go over these a little bit more in a series. I'm going to distinguish between acute early reactivation and chronic reactivation, both with his notes that I've learned like several years ago now, and with my own clinical practice moving forward. Because I think the way that I've practiced has sort of deviated from the way that he treats EBV. So let's talk about it. Okay, let's talk about early reactivation of EBV. This is when you're not quite as sick from the Epstein-Barr reactivation, and it's sort of a start of a chronic illness type of picture where you might feel really, really fatigued for a few months at a time. You feel better for a few months, and then a few months later, you feel bad again. This is sort of like that relapsing, remitting type of picture of EBV reactivation. This is when your body still has the resources to be able to fight off the virus as it comes up, so it comes down again, and then maybe you hit a stressful situation or something happens in life where maybe you have another viral infection. So like if you have like a shingles attack or you get COVID or something like that, then the EBV comes up again, and then you have to deal with that again. So with a chronic early with an early reactivation of EBV, generally when you check the serology, the early antigen IgG will be elevated, and that's a sort of a marker of like how this person, like what the status of the virus is in this person. And generally by looking at the person, you can get a sense of whether or not this is an early reactivator or a chronic complex reactivator. So generally with early reactivation, people feel pretty healthy for the most part, just that they have maybe this debilitating fatigue, and every time they're worked up for the fatigue, other things are ruled out and the cause can't be figured out. So when I say other things, when you have someone presenting with fatigue, you're going to rule out some of the obvious things first, which is, are they anemic? Do they have thyroid issues? Do they have like other nutrient deficiencies like B vitamin deficiencies or iron deficiency or anything like that? Do they have depression that is very obviously not managed? If someone has depression, I wouldn't necessarily like, just throw out the EBV case, but if somebody is depressed and has a history of depression, then maybe that's something that we want to move towards improving before we look into some other causes. But if all of that is ruled out, and then you do have like this history of becoming ill, getting better, becoming ill, getting better again, then chances are you're an early reactivator. And with early reactivation, generally you want to layer on the layer on the antivirals. And from Dr. Paul Anderson's notes here, what I wrote down before is that this is when you would possibly ramp up monolaurin in gram doses, again, for probably a few months at a time before ramping back down. This is when you can prescribe like acyclovir. Typically the dosage is 800 3 times a day for 60 days, or valcyclovir 1000 milligrams, so 1 gram twice a day for 60 days. From what I remember of his lecture, which is years ago now at this point, I think he noted that the acyclovir was a little bit harder to be compliant on just because you do have to take it 3 times a day, and some patients found that very annoying. This is when things like doing higher dosages of vitamin A and vitamin D can be helpful. There was a formula that he mentioned here that's called H2 Plex by Priority 1. In that formula, I looked it up over here. It's got a fairly hefty dose of the retinoid form of vitamin A, which is the form that you want if you're specifically using it for antiviral means. You don't want the carotenoid form. Yes, the carotenoid form is safer because it's not something that will get stored in your liver, but it's not quite as immune stimulating and antiviral as the retinoid form of vitamin A. Also bears mentioning again, the retinoid form of vitamin A is toxic in high doses and is teratogenic in high doses, so please do talk to your healthcare provider before initiating any sort of like higher dose of retinoid vitamin A, and discuss the course of the retinoid vitamin A, because that's not something that you want to be taking for long term. Vitamin A, vitamin C, there's a higher dose of selenium in this formula. There's also lithium as lithium orotate, lemon balm, olive, and L-lysine. So my opinions on this formula are that this is very extrapolated in terms of the treatment for like other herpes family viruses. I think this is a very effective formula for like herpes simplex, cold sores, or like genital herpes and things like that. Like this is very effective for that. Possibly also effective for shingles. But in my opinion, like the L-lysine I think is most effective in terms of dosing high for cold sores and genital herpes. This formula only has 150 milligrams of lysine in 2 capsules, so you would have to dose this pretty frequently. And with dosing that a little bit higher, then my concern would be, is the vitamin A in this too high or the selenium is too high? So I don't, like personally, I don't like using this formula just because I don't have quite as much of that freedom of like adjusting the dose of the different components here. Because I think lemon balm, olive leaf, and lysine are 3 fantastic components for antiviral action, but the lemon balm and the olive I would also dose higher, and the lysine has to be gram doses. And he also mentions a liposomal artemisinin, which I know that he really likes using artemisinin. Artemisinin is great. I think it is a really, really good herb, especially for someone who has a colder constitution. And this is sort of going into the depths of herbalism here, where we're looking at constitution, because artemisinin is a very powerful antimicrobial from Artemisia, from mugwort, and it has been used for things like malaria and other stuff like that. So it's very, very antiparasitic as well as antiviral and antimicrobial. It is a very warm herb though, so if you have a colder constitution, artemisinin or artemisia might be a better fit for you than andrographis, which is my preferred herb. I really like using andrographis, but I also know that andrographis is a very cold herb. So if you have a warmer or hotter constitution, which actually I think because the patient population that I tend to see, a lot of them tend to have some sort of heat in their constitution. That's why andrographis works so well in my practice. I like using andrographis as an antiviral. I think in the early reactivation stage, I also really like using the other herbs as support. So the things that I've discussed in one of the previous videos on what is specifically antiviral to EBV, things like luteolin, things like curcumin, things like resveratrol, licorice, and passionflower. Dr. Paul Anderson does also talk about curcumin and curcumin and boswellia mostly, but he mostly talks about talks about those two in the context of neuroprotection and detoxification in terms of like mopping up all the inflammatory factors that can be floating around post-viral infection. So yeah, for more of an early reactivation type of deal, I would dose things for a little bit longer. I would definitely have this person be on more acute herbs for maybe 1 or 2 months. Generally, in my practice, I see people improve quite dramatically in their energy when we dose them with monolaurin, andrographis, and have like supportive antioxidants like curcumin and boswellia. So curcumin is a turmeric extract, so it depends on like what the supplement name is. Sometimes it will be called turmeric extract, sometimes it will be called curcumin. You can also do turmeric as a spice if you are taking enough of it. But yeah, that's the difference between turmeric and curcumin. Yeah, so that is a pretty general overview of how a early reactivation can be approached. And generally, when I have someone on more stuff in the first 2 months and they start feeling better, then that's when we can start ramping down and then be more on a maintenance protocol. I really like using immune modulating mushrooms sort of as like a long-term maintenance protocol, just to make sure that someone's immune resilience continues to be adequate no matter what they encounter in life. So yeah. Okay, let's talk a little bit about what hospitals are actually doing when someone is hospitalized for mononucleosis, which is an EBV infection. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor practicing in the state of Minnesota. So when somebody is hospitalized for mononucleosis, usually it's because there are severe enough symptoms that they either can't drink, can't eat, or their spleen enlargement, called splenomegaly, is really, really severe. And currently the standard of care in hospitals for this type of situation is primarily supportive care. What that means is that they're not actively treating the infection of the virus. So the treatment generally is hydration, either through IV or other means, nutrition, making sure that the patient is getting enough nutrition, and symptom management and pain management with pharmaceuticals that have those capabilities. In some cases, especially if there's like any risk of airway obstruction, corticosteroids will be given just to see if they can prevent that from happening. But in general, corticosteroids aren't like really routinely given, especially since there's been reviews showing that it only really benefits for maybe like 12-ish hours, and then the benefit kind of dies off. There have been other reviews on antiviral therapies and specific antibacterial therapies that may show promise to decrease the length of hospital stay, but again, we don't have any robust evidence on it. And here's the other issue, is that a lot of the stuff in research usually takes many years to translate into clinical or hospital practice. There's been a very famous study that's been done that shows that the average is about 17 years, which is a whole ass teenager. But in cases similar to this specific commenter here, where if someone is getting repeatedly hospitalized for mononucleosis and EBV infection, that might be something to talk with either their infectious disease specialist about or their current doctor about some of the research that is more forefront right now, or using lower risk, a little bit more experimental, like off-label use of drugs that is low risk for them but might have bigger benefit. Like, this is the art of medicine, right? There's not always going to be like the most pristine, robust research that we have for all of the cases of medicine that are out there. Sometimes when you speak with a doctor, you need to consider the pros and cons of engaging in a certain therapeutic or not, and see whether or not it is worth it when your edge case isn't something that's covered by mainstream research. So in cases like this, I would really look at the research that's surrounding the titers of Epstein-Barr virus and like B-cell infected, Epstein-Barr infected B-cell numbers, and see whether or not dosing an antiviral for a longer term would be beneficial in this case. And there has also been like a really small study on metronidazole reducing the hospital length of stay in patients with severe EBV infections. Although it was a very small study, again, so like this is the type of thing where it's like, if metronidazole is not like a high-risk medication for a specific patient, and the benefit of getting them out of the hospital is really great, then that would be something I feel like would be worth trialing with exploration with your doctor and your care team. And again, because I am a naturopathic doctor, right? I always also like to look at the therapeutics and the herbs that we have right now that have been shown to specifically inhibit the lytic phase of Epstein-Barr virus, and just see if having those as more of like a daily support to inhibit that replication of that virus is enough to decrease the viral replication by enough that it keeps the viral numbers down and the virus infected B cell numbers down far enough that it doesn't go over the threshold of needing to be hospitalized. So to me, the herbals are really low risk for a potentially really great benefit, even though we don't have like the most pristine big studies that like definitively prove that herbs are effective. So that's my 2 cents on the matter, and yeah, I hope this helped. Okay, let's talk about chronic reactivation of Epstein-Barr virus. This is when someone is possibly more sick than they are well in times. Their symptoms can have still sort of that like up and down type of pattern where they feel a little bit better and then they feel worse and then they feel a little bit better and then feel worse. But in general, with chronic complex reactivation, you're going to feel worse more times than you feel better. And when you go dig in to try to find the cause of why you feel so bad, there can be multiple things that start popping up. Very often these people will have like co-infections of several different things. It could be virus, it could be bacterial, it could be Lyme, it could be something else. They generally have some sort of mitochondrial dysfunction because of being so chronically ill all the time. And they might also have some toxic load of something. And this could be like mold or pesticides, herbicides, plastics, or something like that. It could be from exposure, but it could also be that they have been exposed and their systems were so compromised that their detoxification just didn't work quite as well, and that is sort of getting them worse in a sense. So, according to Dr. Paul Anderson's notes, when you have a chronic complex reactivator, generally you will still want to do a very strong course of antivirals the same way that you would treat the early reactivation people. So that's a previous video if you want to check that out. But you would also do a lot of regulation of the adrenals, because the loss of regulation of the adrenal glands is very common in chronic infections. And when I say the loss of regulation, this is mostly going to be subclinical. It's going to be things like you have this feeling of like adrenal dumps every so often where your anxiety is high, or you have salt imbalance where you can't seem to hydrate enough, you have dizziness, loss of autonomic function, so like a lot of dysautonomia symptoms can start coming up here, and you may have a lot of gut problems as well because of the formation of biofilms, your loss of immune tolerance to several different things, your immune system just not being competent enough to drive off any of the opportunistic or pathogenic bacteria that could be hanging out in your gut, etc. So for him, he likes to address the adrenal glands, always repair the gut as you go, and then address the biofilms in certain ways. So what he likes using is thiols, alpha lipoic acid, N-acetylcysteine, things like that. He likes really addressing the mitochondrial function with antioxidants like curcumin, and restoring the energy with things like poly-MVA, B vitamins, iron, with an aim of getting the ferritin between 30 and 50 minimum. For me, I like seeing the ferritin between 50 and 70, so that's where we differ just a little bit, especially for menstruating people in my population. If they're going to be losing blood every month, and especially if they're bleeding a little bit heavier, I want to see that their ferritin is sort of hanging around the 50 mark. It hanging around the 30 mark is still a little bit too low for me, because I see a lot of people who still have a lot of fatigue when they hang around the 30 mark, and then they have their period and then they're completely wiped out. So being at that 50 mark will help with a lot more other things. Like it will help with the fatigue, but if they have any other like neurological symptoms or like random skin itchiness without a rash, that generally does help that picture. Yeah, and repairing phosphocholine, ALA, carnitine, taurine, that sort of thing. And then helping with the cell redox reaction using omegas, tocopherols, which are vitamin E's, ascorbate, which vitamin C's, and glutathione, making sure that the repletion of glutathione and cofactors are all there. So things like magnesium, zinc, B5, selenium, etc. And in general, I agree with this. And I think from my clinical experience, when I see a chronic complex reactivator, what I'm really, really keyed in on is how depleted is this person's constitution? Because a lot of the times when somebody is a chronic complex reactivator, they sort of know this. And by the time they get to my practice, very many times they will have seen like maybe a functional medicine doctor or 5 who have put them on really, really strong sort of kill regimens where they're on really, really powerful antimicrobials or very powerful antibiotics for a long period of time. And this does deplete the system over time. So by the time I see them, generally the adrenal gland dysfunction, that's a dysautonomia, and a lot of the mitochondrial dysfunction are more forefront in this picture. And in general, when they get to that point, it is more helpful to recover the adrenal glands and recover the mitochondrial function first before you go in and reattempt trying to get rid of the pathogen. And in the case where there's a lot of detox sort of bottlenecking with these people because their livers are also struggling, you also have to be aware of giving things that might push phase 1 detoxification without addressing the cofactors of phase 2 detoxification or addressing like sort of the gut issues here. In general, for me, I super agree with the fact that you have to heal the gut as you go. Sometimes you may need to start with a lot of gut healing, addressing the mitochondria and addressing the dysautonomia before you can really go in and treat the quote-unquote root cause, which is this pathogenic front. But before you can have the resilience to be able to kill the pathogens, if you launch sort of a really powerful antimicrobial treatment, you might end up squishing yourself too. So I want to make sure that the patient doesn't get squished. We're only squishing the pathogen. Maybe the patient, we build them up a little bit, and depending on how powerfully we need to address the pathogenic front of things, we might squish them a little bit, but at least we will have built up their resilience enough that they don't like really get squished when we deploy the antimicrobials. And from this standpoint, I think this is the picture in which licorice plays a very good role in. So licorice and passionflower, because licorice and passionflower again are have direct effects on Epstein-Barr virus, but the licorice also has a good effect on the adrenal glands. It is actually the herb that I like using a lot for POTS and that sort of dysautonomia where there's low blood pressure or dizziness. I like using it as part of a formula. Usually I have it in as part of a adaptogenic formula. There is a common extract on the market of licorice that is a standardized extract of roughly 12% glycyrrhizin. So if you look at the back of some supplement bottles that include licorice, what I like to see is licorice standardized to 12% glycyrrhizin. And then in that way, I know that this specific licorice extract will be effective both as an antiviral and as something that will help address maybe the mineralocorticoid imbalance in someone who has adrenal system dysfunction or dysautonomia in some way. The passionflower in general too, in addition to being like antiviral, is also very GABAergic system modulating. So a lot of times people with dysautonomia or like adrenal system dysfunction or mitochondrial dysfunction, they can have a lot of fatigue, but also a lot of anxiety as well, especially if their immune system is also dysregulated in the way that they react to different foods or stress or their environment. The passionflower can be really effective in not only promoting sleep, but also helping someone calm down quite a bit in this process. So those are two herbs that I generally lean on as like more staples when I see a chronic complex reactivator. Usually after I address the systems and introduce like maybe some more antiviral herbs, like I know I keep harping on andrographis, but it is really so great. Astragalus, elderberry, that sort of like. I also like Lemon balm is also a really great one for this, and St. John's wort is also really antiviral. The St. John's wort, again, be careful about, because if they're on any sort of medication, St. John's wort does make certain liver enzymes go faster, so it will reduce the concentration of drugs in people's blood, and if they're trying to keep their drugs in their blood at a certain concentration, then you have to be careful about that. But yeah, this is where I tailor antiviral treatment. Generally, then I also introduce biofilm treatment, and we kind of go as we're watching the symptoms come up and down. So gut healing, mitochondrial support, adrenal support, while trying to progress with the antivirals. Yeah. Chronic reactivators are probably one where you will need the guidance of someone who's willing to work pretty closely with you.